drugstore owner with a pain in the abdominal pain in the right upper quadrant. He has elevated liver enzymes. He has eosinophilia. And he has a CT scan, and this looks not so good. The liver is destructed. There are huge destruction in the liver. You see native portal venous. And now I show you what's happening when you inject your contrast agent. But we just focused first on this area in the liver. You see it's a bit heterogeneous. You have some calcifications, one larger maybe, and it's not so, the margins are not sharp. It's just a region in the liver with some echo-poorer areas, echo-richer areas, and you have an enhancement. But not everything enhances, you have some holes. And these holes, maybe they have a connection, so we really don't know what this could be. Does anyone has an idea what this? Yes, but you're not allowed to say anything because he knows these cases. So you have eosinophilia, you have elevated liver enzymes, and you have some area in the liver with maybe calcifications and some destruction, clearly visible destruction.
Who wants to?
But what kind of echinocosis makes holes like this? Maybe, but I'm not sure. Certainly not a cystic echinococosis. If an echinococosis, then it would be an alveolar echinococosis. But this is not a typical picture for alveolar echinococosis, and you have a washout. So this makes it difficult. When you do a CT scan and you have wash-in, wash-out, destruction and calcification, what is it? It is a cholangiocellular carcinoma. But this is not a carcinoma, and I will show you again. Look at the vascular architecture in this washout region. You see, totally preserved. So it's not a tumor. It's just tissue with inflammation of whatever, and the inflammation leads to a portal venous thrombosis of small portal venous branches, and so you have a arterial supply that is increased, and you have a washout. But the architecture is preserved. Okay.
With these preserved arterial branches.
That's something else. So this is not a desmoplastic tumor with some preserved vessels. This is normal liver tissue. Look at what happens. This is normal liver tissue with a preserved architecture. So this is inflammation. And this is the follow-up. 1 month later, 1 month after treatment. And look what's happening. You saw again these small calcifications, heterogeneous liver. You still have the inflammatory changes. You still have these holes, but they get much clearer, these holes. And you have not holes, you have a tunnel system. You see, there is something traveling through the liver which feeds from liver tissue. It's not yet lunchtime. And this is from Wolfram Wermke, and now it's even in the grayscale picture, it's very clear what it is. It is a tunnel system. And this is what makes these tunnels. It's a fluke, it's a liver fluke. Looks like this, very nice small animal.
Where's the diagnosis?
Fasciola hepatica. It's a liver fluke disease. And this is also, fortunately not yet lunchtime, when it travels through the liver on the way to a bile duct because it wants to lay its eggs in the bile duct, and they go out of the body in the feces. So good appetite, maybe. And we had 11 of these cases, and I just want to show you. This is the follow-up, still the same patient. You see the follow-up. He came maybe about 6 times to me because we had a CT scan and an MRI, and they didn't know what it is. And it was not the first patient I saw with this liver fluke disease, and I said, without injecting contrast agent, I know what you have. And he said, it's not possible, and I'll prove it. We inject contrast agent, I prove it. And I can show you where the liver fluke took its way through the liver. So he came maybe 6 times to me, and I can show this.
This is the same patient?
Yeah.
Of the first picture you put, Daniel, so the one with eosinophilia.
Yeah.
Because I was thinking when we showed this eosinophilia at the beginning, you were maybe thinking about alveolar echinococcosis.
Yeah.
It's not usually so marked eosinophilia in alveolar echinococcosis, so that was a bit
but
strange,
in the fascicular hepatica infection.
Yes, that's why.
Yeah. So this is another patient, one of the first I saw with this liver fluke disease. And again, you see this destruction of the liver, and it's very difficult for a CT scan to see this tunnel system. It's much easier with a sonography. And you see it was 09 with an old machine, but still you can see there are some alterations, some calcifications. And now you see this beautiful picture with these vessels, tortured vessels, because you have a huge inflammatory response. So you have a lot of blood that has to go to these areas. So it looks a bit like a Lewis of the liver, something like Borrelia. So this is just arterial vessel, and you see one of these liver flukes is here, the other is here. This woman had 3 of these liver flukes traveling all over the liver, and she was really ill. And after therapy, you have a huge inflammatory response when the liver flukes, they die. So it's a lot of antigenic material around. And this is what you can see after a certain time. You just see calcifications. So when you treat it, you see several calcifications. So these small animals, they die, and you have calcifications of these tunnel systems, and especially of these animals. And in the end, you cannot say what it is. It's just a scar, just old hematoma, just an old parasitic disease. It looks like this after a certain time. And of course, you can look what happens, but this is not. Even if you have some enhancement, this does not mean that there is something remaining. Sometimes you have a scarring, and where you have a scar, you have a dense arterial vessel system, so it may make you an enhancement. In this case, you see just this is remaining calcifications and a scar. So,
questions? Maybe?
Questions?
Yeah.
Yes. Yes. In the first case, it was normal. In the second case, I'm not so sure. But the animal died before it could enter really in the choledocus.
So when you see now a patient like the first one, so at the first presentation, you thought that it could be an alveolar echinococcosis, right?
No.
No. Also on the first one.
The first one, this was the owner of a drugstore.
Yeah.
This one,
you already thought that it was not an alveolar echinococcosis on the first image.
It was an absolutely classical picture of a liver fluke disease.
So you already thought it on the very first examination. Yeah, very good. And maybe not. I don't know if everybody knows why we are talking so much about alveolar echinococcosis in this course. Do you know? There is many. Swiss people, who knows, but maybe.
We have a lot of these cases
Yeah,
in Switzerland.
exactly, but
Yeah.
I don't know if
Yeah.
they know, because this is
Yeah.
something very rare in other areas of
The
Europe.
cystic
so-
echinococcosis is rather rare. So we have this migration also from the eastern part of Europe, and we have also this cystic echinococcosis. But 10 years ago or 15 years ago, I just one. I saw just one, and now it's every year I see
More
one
and
or
more.
two or even more. So
Very good, because
growing.
working in Spain or in Italy, you are not at all used at
Mhm.
seeing patients with alveolar echinococcosis. Something very, very rare. Very good.
Okay,
You like to go to the?
shall I continue or do
Yes.
we want
Yeah,
to?
yeah, you can continue. Please.
Okay, let's look at this situation here. This is a woman, and you have a destruction of the liver. You have calcifications. You have an area not well defined, just doesn't look very good. And you have also some dilation of the bile ducts, so something like a Klatskin-like tumor. And you have some, you see here, this is the portal venous system, and you have a high blood flow, so something like a stenosis in this area. So we really don't know what it is.
The portal system,
Da.
you had
Da.
different flows. You have one flow outside and another one inside.
Yeah. This is just in this direction. Yeah, this is the flow inside, or in the direction inside the liver. Or what do you mean? This one here?
Normally you have the artery and the portal vein that have the same direction.
Yeah,
as the blood flow.
yeah.
And here I have the impression that it's one in one side and the other in the other side.
I think we will see this more clearly in contrast enhanced ultrasound. But what it seems that there is some mass in the liver, some infiltration, and we really don't know what it could be. So let's look at the contrast enhanced ultrasound, and we focus on this region first here. And what we see is we have a avascular area here, and we have in this area where this tumor, and here you see again this stenosis of the portal venous system. The margins are much clearer with contrast enhanced ultrasound, and you see small cystic infiltration wherever you look at the margins. I showed you this before. Look. This is just some small animals maybe eating the liver, but it's not the same as a fasciola hepatica, and it's growing. You see there is also some small cystic infiltration along the portal venous system, along the bile duct. And you have an inflammatory response in this area of the liver. You see a wash-in where you had a washout, so this makes it even more difficult. So we have the impression that it's an infiltration of the liver, not like a cholangiocellular carcinoma. You don't have any vessels going from outside to inside in this desmoplastic tissue. You have some necrosis or some area without any vessels, and you have small cystic infiltrations. So this could be, we had it before, alveolar echinococcosis. And this is how the CT scan looks. It's very difficult. It's always difficult to say something when you have such a destruction in the liver. And we had antibodies to this echinococcosis. alveolar echinococcosis, and the patient was operated, and it's not a very good photography, but you can see what I showed you, these small infiltrations here, here, here. The margins are very important when you have the impression that it could be an alveolar echinococcosis. Always do a serology, because it changes the procedure. And of course, you have the histologic picture of a typical echinococcosis. This is pictures from pathology Inselspital. Yes, wonderful, huh? With a cuticula, whatever you want. And this is another patient with a alveolar echinococcosis. When you have a bile duct erosion, erosion, how do you say in English? Erosion. So when you have a contact between the fluid, or the bile fluid, and the echinococcus, it gives you makes a necrosis. So it looks like an abscess or like a tumor. But when you look at the margins, again, there are small calcifications, and then you change your probe, or you just magnify with the other probe, you see very clearly small cystic infiltrations, even with grayscale sonography. So here you have to say, this is maybe a typical picture. Of course, you have in this situation always to do a serology, and when you look at the contrast enhanced ultrasound, again the same as I showed you before, but this time with a large necrotic liquid area inside. This is not an abscess. This is a bile erosion, contact of bile fluid with the echinococcus, which makes you such a picture.
How can you exclude this is a cystic cholangiocarcinoma?
I see no vessels going from outside to inside. I just see, you see, this is the echinococcus, and it makes these infiltrations. If you have a serology which is positive, I think you can rely on this. You don't have to do a biopsy. You can do a biopsy. We have a lot of echinococcosis proven with biopsy, because it's not always easy to diagnose it. So I agree with your comment. So this is the picture of the CT scan, and this is another patient which has been sent to me for biopsy. Tumor in the liver, and I should do a biopsy, and I thought this is not a normal tumor in the liver. And again, if you look at these margins, you have to say, before I do a biopsy, I want to have a serology. And the serology was positive, and I did not do this biopsy, because it's, you can do a biopsy, you can prove that it's alveolar echinococcosis, but sometimes the echinococcosis goes outside the liver and makes you peritoneal echinococcosis, and this makes it much more difficult, and the surgical procedure is very different from when you have a localized echinococcosis. Okay, these are my cases, and we go on, I think.